Welcome to Stethoscopes and Student Standpoints, the official podcast of the Alberta Medical Association, AMA, Medical Students Advocacy Committee, and the first ever inter-school podcast led by medical students in Alberta. My name is Sana.
And I'm Abdullahi.
Today's episode is actually not led by Abdullahi and I, but instead we have one of our colleagues, Adam, who is helping us here run this podcast and is also a medical student from the University of Calgary. And he had a really insightful discussion and interview with Dr. Rithesh Ram, and he's the president of the section of rural medicine within the Alberta Medical Association. So they have a really great discussion for us here, and it's focusing on the rural healthcare shortages within Alberta, including a breakdown of the current situation, an overview of current and potential solutions, and what medical students should know about the situation. So let's get right into their interview.
Welcome, everyone, and thank you for listening. Before we begin, I'd like to introduce our guest, Dr. Rithesh Ram. Dr. Ram is a dedicated Albertan who grew up in Camrose, currently works as a family physician in Drumheller, Alberta, and also operates in many positions, some of which are the director of the University of Calgary Longitudinal Integrated Clerkship Program, otherwise known as UCLIC, the president of this section of rural medicine within the AMA, or Alberta Medical Association, and a clinical assistant professor in the Department of Family Medicine at the University of Calgary. Dr. Ram is heavily involved in rural healthcare advocacy and has kindly agreed to join us for our topic today, which is healthcare shortages in rural Alberta. Welcome, Dr. Ram, and thank you very much for joining us.
Thank you for having me, Adam.
Of course. So I'd like to start actually by hearing a little bit about yourself and your journey to becoming a family physician in Drumheller. I understand you're born in rural Alberta in Camrose and currently maintain a very diverse practice in Drumheller, including a chronic pain clinic, as well as some acute care provided in hospital, emergency department, operating room, and long-term care facilities as well. So why don't you fill us in a little bit about your medical story, from growing up in Camrose to operating such a diverse practice in Drumheller and becoming so involved in rural healthcare advocacy?
No, absolutely, Adam. And I'll preface it by saying I know by training I'd probably be a family physician, but I'm actually a rural generalist, and I'll get to what that means probably by the end of this intro. So yeah, born and raised in Camrose. My parents immigrated there back in the 60s. So as far as I know, I've been Canadian and Albertan for as long as I live. I decided right when I was leaving Camrose that it's kind of like the Wile E. Coyote, Looney Tunes kind of conversation that if you ever watch those cartoons. I left Camrose and I had TNT behind me and I lit it and I thought, you know what, I'm never going back to rural ever again. And off to Edmonton I went, and I actually did my first degree was actually in electrical engineering. So I was doing that degree. I loved it. It was a great experience as far as the degree, great university, but I just couldn't see myself doing that actual job. And there's lots of reasons why that was the case. So by the end of my degree, I had a position that I was actually supposed to take and actually accepted. But then I decided I was going to go back to school and I wanted something different. I didn't want to do something that was really engaged in my engineering. So I decided to do a PhD in epidemiology, and I decided to move universities to do that at the U of C. And then part of the way through my second year of my PhD in epidemiology, I remember very vividly the professor came into the room and said, "Hey, today class, we're going to spend the first 45 minutes explaining what it's like as a healthcare researcher," and went on to explain how you never have a real job, you're always fighting for your grants, you never really know how you're going to make ends meet on any daily basis. And I walked out of that 45-minute session going, "Oh, wow. I gave up, a 5-6 figure job, and now I don't even know where I'm going to be over the next few years." And the way it is in epidemiology and community health sciences at the U of C is that at any given time, about a quarter of that class is usually a physician doing a master's or a PhD. So I have a lot of friends that were physicians at the time that said, "Hey, why don't you go and get your MD at the same time? That way, you can still do your clinical practice, you can make ends meet, plus you can do research on the side." Now, what they forgot to tell me is that they meant research on the side of your desk, not necessarily, research dedicated time. But anyways, sounded like a good idea at the time. So I applied, I got in, I joined the Leaders of Medicine program and ended up in an MD PhD program. Now, just by default of my background, I thought I was slated to be in academia. I had to be an academic position. And with the PhD background, a lot of my friends being in it, I thought internal medicine was the only route. Like I had the full on blinders on. I was like, internal medicine is the way to go. I did something like 16 weeks of MTU. So I'm a UC grad, obviously, 16 weeks of MTU, electives, everything at ICU, CCU. And towards the end of that internal medicine block, literally my last 2 weeks, I kind of came to the realization that maybe the preceptors and all the physicians just weren't as happy with their lives at the time as I thought they should be. So I kind of re-engaged with my friends and said, hey, I know you encouraged me to do this and this is what you think I fit very well in, but do you have that balance? Do you like what you're doing on a day-to-day basis? Do you see yourself doing this, 40, 50 years? And to be honest, Adam, most of them said no, which was a bit of a shell shock for me because up until this point, and as you know, in a 3-year program, I was fully dedicated into doing IM. All my electives were that way, all my letters to CARMs. So I did a full 180 and I tried to re-engage with what the rotations that I had left. So I had psych left, and then I had about 2 weeks of family medicine left. So I went through psych, tried very hard to convince myself that psychiatry was the way to go. I have a lot of great friends that are psychiatrists. I applaud them, but I got to the end and I thought, you know what, do I really want to get rid of my stethoscope? I mean, I tried to convince myself very strongly. Then my 2 weeks of the 6-week block of family medicine actually was in Crossfield with Robert Collingridge. Dr. Collingridge is a fantastic rural generalist. He's a rural physician. He's a rural generalist. And in that 2 weeks, I re-realized why I kind of went into medicine in the first place. It was so that I can be engaged as a generalist, so that I can have that full breadth and depth of scope. So I changed everything again for the third time. Typical medical student just can't decide what they want to do going into CARMs. I changed everything again, sent only family medicine, uh, CARMs. That's what I focused on. And I did exactly what, UME tells you not to do. And I said, well, I had a young family at the time. My wife was going through medicine as well. And I said, you know what, I'm only applying to Calgary, and that's it. So I only applied to the Calgary Family Medicine program. And probably what's surprising at this stage, given where I am right now, is that I only applied to the urban program. And I can go back in time and I can blame myself, blame the fact that I didn't want to be away from the family, blame the fact that I, didn't want to be uh, away from them or from the kids. And, wife was going to be pregnant again. But at the end of the day, that absolutely was a mistake. I'll acknowledge that right now. But thankfully, I got into the urban program. And through that, I got fairly discouraged with urban practice, like horrendously so. And I think I talk about that in blogs, and a lot of my colleagues have heard this. At one point during my training as an urban resident, I had honestly decided that I didn't want to be a physician anymore. I didn't see myself doing urban practice. It's just not for me. The disengagement, the lack of control of your patients, the inability to use all of the stuff that you're learning, like all the stuff that you're learning in medical school, you're learning the full breadth and depth of medicine in medical school. And then you go to residency and you get pigeonholed into these niche practices. And in family medicine, urban, it's very much that way. So I was very discouraged when we had a plan that when my wife finished, that I was going to go back to school and do an LLB MBA and kind of switch focus entirely. So during my second year of residency, like everyone, they have a rural mandatory block. So during that rural mandatory block, I had scheduled it to be during December. And the reason I did that is because I had already made in my mind that I was leaving medicine and I didn't care that where I was going. I just wanted to be close to Calgary and I wanted to have a lot of time off. So I scheduled it around this Christmas time because you get the CARMS break. And then I added in some other vacation time up to the max that I could have. So I was going to be away from Calgary for the least amount of time. And I picked Drumheller because it was close, and I had some colleagues that said, hey, that's close. They'll work with your schedule to see what you can do with it. So off to Drumheller I went. And when I got there, there's a lot of other stories I could probably tell in there, but I'll try to shorten it up. When I got here, the engagement that I had with my patients, the autonomy, I got to see finally the full breadth and depth of practice of what it means to be a rural generalist. As you said in the beginning, when you're a rural generalist, you have your community practice, but you also have your hospital-based practice where you are running the emerge. You are the hospitalist, the internal medicine doc that's running the hospital. You are also the person they call on when there's an emergency C-section to do NRP for the newborns. You're the ones they call on to do assists when it's general surgery cases or anything else. You're the one that's also taking care of on any given week when you're hospitalist, the 110 patients that are in continuing care. And this is notwithstanding the breadth and scope of patients that you're seeing in your clinic. And I bring that up specifically because when we see patients in our clinic, we don't have the luxury of just punting them off to dermatology to do simple things like a cryo treatment for a wart. Like we actually do all those things. We don't have the luxury of punting them off to dermatology again to do just regular biopsies or excisions. We don't have the luxury of punting them off to radiology outpatient to do MSK injections. Like, so we do all of that. So we do all of that breadth and depth of scope. And I saw that when I was a resident. So I remember very distinctly, I came here and then, 4 days or 5 days in, so I went back to Calgary. And up until that point, like I said, I told my wife that I was going to be shifting away from medicine. And when I went back that first weekend from that rural rotation, she kind of saw a new light in me. She's like, there's a twinkle in my eye again. I was talking about medicine up until this point. All I talked about was leaving medicine. And she looked at me and she said, I think you like what you're doing now. And I was like, yeah. Yeah, this is like it basically it showed me again what medicine was supposed to be like, what I thought I was going to be when I got the title doctor. I thought I was going to be that person that if there was an emergency on an airplane and someone asked for a physician, that I could be comfortable put up my hand no matter what the case was. And that's what a rural generalist can do. There's virtually no other physician discipline that can do that. Emergency docs can handle a lot of stuff, but you don't have peds, then how are you going to put your hand up for a peds case? Or you might have forgotten all of your OBGYN stuff by that point. But as a rural generalist, we got everything. And I wanted to be that person, and I can be that person here as a rural generalist in Drumheller.
I think that's fantastic because it really showed already some of the benefits of being a rural doctor, which we're going to get into a bit later as well. But also how diverse of a pathway you can take for getting or pursuing a medical career. So thank you so much for sharing that. And on that topic as well, I'm curious to hear what challenges you may face. What are some downsides of being a rural family physician, either historically or currently, and how does this impact your patients?
So it does take a particular personality and mindset to be a rural generalist and to do work in rural areas. What I love about it is having that absolute control of your patient journey, knowing that you are the one that's going to have that full continuity of care, whether it's in your clinic, whether it's in the hospital, and you are more responsible for the patient, I would say, than you would be in an urban practice. And that can be scary for people. I mean, we see that when I get residents and students that we're talking to, there's a lot of sense now that, you go to a rural area and suddenly, yeah, you're doing a quote unquote family medicine block, but you're coming and you're only spending 40 to 60% of your time in the clinic, and the rest of it, you're in the emerge. You're dealing with potential traumas, you're dealing with um, chest pains, you're dealing with PEs, you're dealing with all of the procedure stuff that you could be doing. And then we toss you into the acute care and you're dealing with internal medicine cases all by yourself. You can't just consult IM or consult, neurology. This is the stuff that you have to kind of deal with firsthand. Obviously, if a patient's doing really poorly, you send them off, but in general, you're still the one taking care of it. So it is a challenge, and it's a certain personality that wants to always have that actual learning sense. So I know we talk about in medicine, you're always going to be a lifelong learner. Well, as a rural generalist, when you are the one that's in charge of the emerge or of the hospital, you're definitely on your feet all the time. And there's definitely times where you're going to be learning constantly. I know when I think they still talk about it that when you're going through residency, by the time you write your final licensing exam, most residency programs will say that that is the smartest you will ever be because you've been studying so hard for it, and which is happening right now. All the residents are going through it this week. You'll be studying so hard. This is the most knowledge you're ever going to have, and after this, unless you really are diligent, you'll kind of slide off. I can tell you with absolute certainty the smartest that I have ever been, or the most engaged that I have been, was my first year of practice in a rural area. I was listening to podcasts all the time. When I say all the time, I mean when I was in the car, when I was working out at the gym, like anytime I was like, oh, more CMEs, more everything, just to gain that knowledge because you have that responsibility and you feel bad, especially when you're a new grad, you feel bad if you can't handle a certain situation. So then you want to read up on it. You want to get comfortable, you want to learn, and you want to go forward. And that, like I said, takes a certain personality. So it is a challenge. It is a challenge for people that are thinking about going to rural areas because that is something that the community expects of you and patients do expect of you.
Some of that aligns with kind of some of the things that I've been able to find as well. There have been some surveys of rural Albertan family physicians, and some of the examples that they have included are, complex patient panels with limited access to specialists, high on-call burden, outdated equipment or facilities, and a worse work-life balance as a result of many of these things. And shortages in rural healthcare obviously are a very serious issue that continues to negatively impact the overall health outcomes of rural populations, and the data is there to back it. There was a study by Sujendra Subedi and his colleagues at the Health Statistics Division of Statistics Canada, which analyzed how geographic remoteness relates to preventable and treatable mortality rates across Canada. And this data was from 2011 to 2016, and they used a remoteness index, which conveyed degree of remoteness from larger population centers and therefore the health services they can provide. And they found a very clear pattern of significantly increased preventable and treatable mortality rates related to how remote you are. Now, this is from a national lens, and of course, the data is a bit dated now, but I'm very curious to hear what are your thoughts on the current standing of Alberta's rural healthcare situation? Has there been any improvement when you compare it to the past in terms of accessibility and patient outcomes?
So I'll answer the first part. There
Sure.
hasn't been any immediate improvement. However, we have seen, especially in this last government, that they're looking to focus more on rural and remote areas than governments have in the past, for sure. So the recent announcements with regards to improving the facilities and technology available in rural areas is probably one of the most recent examples. And it's very hard and challenging, obviously, to try and convince new grads or IMGs to go to a rural remote area when, the first thing they go and look for is, well, what kind of equipment do we have? Do we have a CT scan, or how far is it? Do we have an ultrasound, or how far is it? If I'm going to have to do specific procedures on a patient, do we have all the equipment? Do we have something as easy as a tonometer for looking at if someone has glaucoma just in the moment? So there's certain things that if you don't have it available, and you take it for granted when you're going through training, especially if you're going through training in the cities. There's everything available and everybody available. So if you can't find it, you got to know the equipment's available for you. So updating that equipment and updating the facilities is a big key point to ensuring that we're gonna have appropriate and accessible and safe care for patients. There is a lot to say, obviously, about you can't have facilities without people, and we know there's a big health human resource crisis that's stemmed from the last, I would say, 40 to 50 years of policy development. So we're not going to fix that overnight. But at the very least, one of the steps that they can do is upgrade, purchase, and increase what we have available in rural areas. So that's the direction they're going. Again, we'll see how far they get. I've always been of the standpoint that in rural and remote areas, we should actually be the ones that are piloting the most innovative and new stuff. So when a new blood test comes out that is going to help us determine or help us facilitate our clinical gestalt around heart failure, as an example. So BNP would be the case. So when BNP first came out, it was only available in the cities first. Now, for me, that was a ridiculous standpoint to take. Knowing that you have cardiology just around the corner in every given tertiary care hospital that you have. So why would BNP, which is a marker for heart failure, only be available as a trial in the cities? That should have been a trial out in rural remote areas, because obviously that would help us more when we don't have cardiology, that we can, hey, walk down the hallway and chat with them and see what that was going on there. So it's that kind of stuff that needs to change. I don't know if that will. The purpose of the recent announcement wasn't necessarily to go down that road, but I do think if there's piloting of new, innovative, investigative processes, whether that's DI, whether that's lab, that should be done in rural and remote areas, because we're the ones that need that support. So you might as well do the trials there, not in downtown Calgary, downtown Edmonton. That doesn't help anybody.
Yeah, it's actually, it's interesting to hear that perspective of the fact that it hasn't maybe improved, because one would assume that, with this ongoing attention to this problem and continued discussion regarding solutions, that it must be improving. But I think that's quite a unique perspective to hear, especially from someone in your position. So I think I'd like to discuss some of the solutions that are currently in place, and then like to hear your thoughts about those and what other solutions might be potentially better at solving the problem. And I think we started to get into that, but you already mentioned, sorry, that there was this increased investment into Alberta's healthcare system by the government of Canada. It was $1.06 billion in 2023. And with that, the Alberta government put out some of those following goals, like increasing diagnostic imaging capacities in the community, greater access to digital health services, things like that. And so it does sound like, from what you're saying, that it's a step, but it's maybe not, not that much actual tangible progress at the moment. As well, I think it's worth noting that both medical schools in Alberta the University of Calgary and the University of Alberta, received additional funding and with which they increased the number of seats available. So they increased by 120 seats to be added incrementally over the course of 3 years at each school. Now, increasing the number of medical students will increase the total physician population, but it will not necessarily increase how many people will commit to rural practice. So one of the other methods, of course, of attracting more physicians is, as far as I'm aware, the primary method is largely through monetary compensation. As there's the rural remote northern program is one example. They offer greater monetary compensation to those working in underserved areas, and they started in 2007. As well, many rural centers offer signing bonuses, and I think this is, of course, important to be aware of. But these are kind of just the surface level of the solutions that are in place. And I'm curious to hear your thoughts on them. Are they working? Why or why not? And what other solutions should be explored?
So it's a tough question, Adam. So it's obviously multifactorial as you kind of identified. So there is many reasons why a pre-med student, med student, resident, and then finally your resident may or may not choose to go to a rural area. So we'll come back to the very obvious ones like monetary compensation, but at the very least, by the time you progress all the way through medical school, there's a significant population that has significant others, and some will have families. So when it comes to moving to rural remote areas, we always have to consider the other factors that play into someone's life. So if you do have a family, or if you do have a partner, if that partner doesn't have something they're going to be doing in this rural remote area, job or otherwise, it makes it a little bit challenging to say, hey, we're going to move out to this rural remote area. I'm going to have a job. I'm not sure what you're going to do, but we'll figure that out later. I know we're in the age of, there is way more industries that have work from home stuff, but that still is pretty limited. People still, for the most part, I think, believe that they want to have some of that human engagement when it comes to their workplace. So if we don't take these other factors in consideration, then it makes it very hard, irrespective of how much you're going to pay someone, that you're going to overcome we're going to call it burden of what their family and life looks like. So if we don't have appropriate childcare places, if we don't have the appropriate availability of schools, if we don't have the appropriate extracurricular leadership activities for their kids, we already talked about the fact if their spouse doesn't have a job or doesn't have a community network or that social frame and that network, then even if you attract someone to a rural area, you might get them for a few years, but eventually all of that other life stuff attached to your families might drive them away sooner rather than later. So that's a big thing, and that is one that I don't believe the provincial government really should have much say in it. I think that's up to the municipalities. And I know there's various places across Canada that realize this and are taking it into consideration, but it's very much a patchwork kind of project right now. There is no universal look at that, but that needs to be taken care of. Now let's go on the flip side. Let's say, yeah, no, I actually don't have a partner. I don't have that we'll call it again, family burden that's attached. Then again, most human beings, once they're finished school, might be looking for that. So again, if you're going to go into a rural area and you are, let's say, single, and there's no social network, there's no interactions, there's no community base that you're just going to be popped into, it makes it very challenging. It's challenging enough in the cities, but to go into rural areas where that whole social atmosphere is limited or seen as limited can be very challenging. So again, if municipalities don't develop ways to have the after work social ties, and whether that's for kids, for families, for spouses, or for single physicians, then they're just, there's only a certain amount of compensation that's gonna bring someone to an area without having those. So I think that other, we'll call it the soft side or the social side, really needs to be taken care of. I know a lot of the focus comes from, as you mentioned, the incentivizations. People are there's lots of areas, we see it in the news all the time. They're buying physicians' houses, they're giving them, signing bonuses, they're doing all sorts of things. And attached to that, sometimes they'll attach them to a work agreement where you have to stay there for a certain period of time. But I'll be honest, my personal opinion is that if you attack, meaning if the municipalities attack this social life side, they might be as much or more successful as just attaching themselves to the incentivization compensation side. Don't get me wrong, I'm not saying the compensation doesn't have to be there. 100% physicians in rural remote areas need to be compensated far greater than they are in any urban center, hands down, as a base. That has to be there as a base. Alberta does fairly well with that. We still have a lot of room to work, but as a base. There's lots of studies out there. I can't remember the names of them, but the most recent ones that I was looking at is that in order to incentivize someone to go to an area they didn't expect to go to, not an area they didn't want to go to, but an area they didn't expect to go to, you actually had to incentivize the compensation at 30 to 120% of what they would be paid in a city or urban area. We are nowhere near that level, nowhere near that level. So if we're just talking about the incentive and compensation, we have a lot of work to do. That would be the base. But I really think municipalities is missing the boat if they don't tackle the other side that I mentioned.
That's interesting to hear because, I don't think I've heard that addressed, like that whole social side, which obviously must be a major factor in someone's decision to move to an area like this and potentially, take on a job. Now, if you wouldn't mind, I'd like as well to shift our focus to medical students who are, obviously the future generation of physicians and play a big role in working towards resolution of this problem. And so I feel that, as a University of Calgary student, there was actually quite a good amount of exposure to the possibilities of pursuing rural practice through information and lectures, hands-on opportunities, through programs like the Rural Health Physicians Action Plan or RHPAP, which facilitates things like rural shadowing, supported housing, and things like that. So, for all the medical students who may be considering rural practice, and I think maybe we may have touched on this at the start, what would you say are the greatest benefits of being a rural physician?
Well, if as being a rural physician, so probably the things I said, you are the I'm going to go out and say it. My colleagues will probably chagrin at this, but you are the most competent physician in the broadest level of specialties that you can ever imagine. And this is by default of the job and the responsibilities that you have to your patients, to your community, to the hospital, to your clinic. So, and that brings a certain level of pride. Like you can go to any conference, like I said, you can be on a plane and be confident that no matter what is coming up, you can likely deal with it in some way, shape, or form because you have a framework to deal with every emergency that's going to be coming your way, irrespective of it being a newborn, pediatric case, adolescent, geriatric, or just a regular adult. You are there, you are ready, and that there's a lot of pride that goes into that, and that's what a rural generalist is. From the point of view from training, though, and as UCLIC director, I tell you guys all the time, the whole point of medical school is to come out the best trained that you could possibly be. And I see it as logical, but usually I have to nuance this a little bit. Wouldn't you want to be trained in what I exactly presented as the best possible breadth and depth and scope of generality of medicine that you could possibly be? There is zero chance of getting that in the city. Zero. So right now, for University of Calgary at least, if you're a UCLIC student, and we have lots of data to show this, if you're coming out of UCLIC far above the level of your colleagues that stayed in the city to do their clerkship. And we know that from information that we've gotten from residency programs, from clerkship directors, from lots of people over the years. Everyone in UCLIC, for the most part, comes out at the level of an R1 or R2, about two-thirds or three-quarters of the way through clerkship. Like they're already at that level. So you can't say that as a generality for anyone that's doing the traditional urban clerkship, but you can say that in UCLIC. So at the very least, for medical students that are listening, I would say if you're trying to be the best that you can be, I sound like a U.S. Army post right now, but if you're trying to be the best that you can be, then you want to be trained early. Does that mean you have to end up early? No. But if you could pick the best that you want to be, then UCLIC and having as much rural exposure is the way that you're going to do that for yourself. And this is irrespective of the car specialty that you're going for. We've had people that got into ophthalmology through UCLIC, radiology through UCLIC. It doesn't matter. Like the residency programs see you and they see you in your R1 and R2 years where you're undifferentiated for any specialty. And it's the UCLIC students, it's the LIC students, it's the rural students that have that background that the preceptors are automatically looking at and saying, hey, you're probably more competent than everyone else here. I want you, and I want you to come with me right now. I have a story about that. So my wife she's a much smarter person than I am. So she actually did UCLIC and then she did the rural residency program as well. So during her rural residency, I remember she tells the story about being on her ICU block and the very first day, and ICU is chaotic. So anyone that's done a ICU rotation already will know it's chaos, right? It's busy all the time. You're working 24 hours, no matter what. You never see your call room. Great rotation, by the way. I loved it. But she tells the story on her first day. There was three traumas happening at the same time, and her preceptor, ran by the group because they're all new groups. There's, R1s, R2s, there's internal medicine docs, there's internal medicine residents, general surgery residents, her as a rural family medicine, and I think one other one that I can't remember. But the preceptor ran over and said, hey, you guys, get a handle on these stable, quote unquote stable patients in the ICU, but there's a trauma over here. I know one of you is the rural medicine doc. Who is a rural medicine resident? Who is that? He put up her hand and he said, "Hey, you're coming with me." And then off they went. Like that is the type of experience that people know is coming out of the individuals that are going through the rural programs as opposed to the urban programs.
Well, I will say you framed the UClick program quite well, and that kind of addresses my next question, which is going to be the benefits of UClick, which sounds like there's quite a few. There's some interesting data as well that kind of highlights U of A's success with longitudinal integrated clerkship programs and how with their students, at least this is from 2009 to 2016, they were found that their version of UClick or their integrated clerkship program, where you have more rural exposure and more rural experiences, it actually was successful at pushing students or encouraging students to end up in rural practice. So I was wondering if, what does the data say about the effectiveness of UClick with that regard to increasing pursuit of rural practice for U of C students?
Yeah, so it's very similar. So all the LICs, so all the longitudinal integrated clerkships across Canada would have very similar data. So for UClick, we have data and we published it around the same time. So since our inception, we're the most successful program that Alberta's ever had to end up with people that are finishing and practicing in rural areas. I can't promise they're all Alberta, but at least in rural areas. And the stat is two-thirds. So at least two-thirds of grads since the start of UClick ended up in rural remote areas practicing and living, which is a phenomenal stat. So that stat is similar to NOSM, which is obviously is a school based on the fact that they wanted to produce rural generalists that were going to stay and practice in Northern Ontario. So it's a very similar statistic. But a lot of the LIC's longitudinal integrated clerkship programs will have similar stats. But for Alberta, UClick definitely has that one. I don't know, I apologize. I don't know off the top of my head what the stat is for the non-UClick students. I would imagine it's in the single digits, but I don't know that off the top of my head. So having two-thirds of UClick going that way is phenomenal. And like I said, not all the grads are doing rural family medicine or rural generalist practice residencies. We even have people that are doing their general surgery. They go in, they do their general surgery rotations and their general surgery CARMs, and they still end up in regional or rural areas because that's where they found that they have the greatest depth of their own specialty practices. That's probably one of the other unique things is that you can have a rural generalist or you can have, sorry, a general surgeon. So when they're doing their practice in the cities, they might be pigeonholed into doing hernias only, or they might be pigeonholed into doing very specific things within general surgery. The general surgeon in Drumheller does everything. Does choles, does appies, does, hemicolectomies, will take care of, the actual full breadth and depth of what it means to be a general surgeon, does EGDs, does colonoscopies, does everything. And you can't say that about a general surgeon that's in Calgary either. So it's not just the rural generalists or the family practice guys that are doing the full breadth and depth and scope of medicine. It's also all the other specialists. Our internal medicine doc is probably another one. We're lucky enough to have one, and his full breadth and depth of scope of what he does, like the stroke knowledge that he has for acute, the CAD knowledge that he has that he deals with. He deals with all of that, and he helps, and we function as a team together versus having to punt everybody off to all the specialties that you have in the cities. So you just, like I said, if you're someone that's looking at your training and looking at residency and looking at your life and saying, I want to be a specialist in one way, shape, or form, but I want to use all the knowledge and all the training that I got, no matter what specialty you are, rural regional is the way to go.
Well, it's interesting as well that you mentioned that because um, I think based on what you said, it sounds like expanding, funding for UClick or for longitudinal integrated clerkship could be a great way to promote people to go towards rural medicine and could contribute to fixing that rural medicine shortage that we're talking about. I guess as well, I'm wondering, are there any drawbacks to pursuing UClick for those medical students listening?
Well, obviously I'm biased, so I'm going to say there's no drawbacks, but it does take, as I said, it does take a certain personality and mindset. So it's especially, if you're someone that has been born, bred, and raised in Calgary, let's say, and you've never left other than going to the airport, that's the farthest if you've gone rurally. It can be a daunting thing to say, hey, we're going to go out to Drumheller. And maybe you went there to go to the dinosaur museum, but that's all you did. But you're going to have to go there and live there and get integrated. It's a challenging thing, but there's a lot of stereotypes and there's a lot of stereotypes that are built in there that people don't understand. So one of the ones that I usually talk about, especially being someone that's an visible ethnic minority, there's a concept or thought out there that somehow in rural Alberta, there's going to be more discrimination against you, more prejudice against you, and it's just going to be bad, and I need to stay in the city to protect myself. I can tell you, Adam, with 100% certainty that I was more discriminated against in Calgary than I ever was anywhere in rural Alberta. If anything, anywhere in rural Alberta, they are more understanding. They will speak and want to ask me questions about either, what I know about various cultures and where I want to go with it. The typical question, and this incest me to no end, that I always got in Calgary when I was either medical student or resident, was a patient would ask, and this again, it's a very jarring question, is where are you from? And I would say, well, I'm from Camrose. And they'd say, no, where are you really from? And you can imagine what that does to someone is, actually, I was born there, and I've probably been in Alberta and Canada longer than you have, but fine, you're gonna ask me where I'm from. I never get that question in Drumheller. And I've been here coming on 10 years. And maybe they could read my blog and understand where I'm from, but I never get those questions. They're way more understanding. I'm not saying there's none of that in rural Alberta. There's no racism, no discrimination. Obviously, it's there. What I try to relay to students is that it is far less.
So I think Dr. Ram actually that addresses very well, one of the common misconceptions about a potential drawback of UClick. Now, the last question I have for you, Dr. Ram, is what your recommendations are for what medical students can do to advocate for, contribute to improvements in rural healthcare. And I know it's a loaded question, but I think in a person in your position where you're engaged in rural healthcare advocacy, I think it'd be great to hear for medical students and for residents or whoever else is listening what they can do if they want to if they feel like they want to get more involved in rural healthcare.
So I can probably even run that, but for rural healthcare, really just healthcare. Like if you want to be a leader and an advocate and ensure that you are trying to move the needle, improve the system, big or small, the biggest thing that I think people need to realize is you have to work with the funders that are providing the money to make the services run. So I know the instinct, the visceral reaction is to go, government's bad, government's doing everything wrong. You know, we need to rally, we need to show them that they're doing everything wrong, and this do this in a very confrontational manner. That is 100% the wrong way to do it. You can't. It's kind of like growing up. Anyone that has parents that got an allowance. If they're giving you an allowance or they're allowing you to do certain things, you don't really want to get into a scenario where you're fighting them on that because they're the ones that are trying to help you. They're the ones that are trying to engage with you. Government is very open and willing if you're having a dialogue and you're willing to partner with them to tell you very openly that they're not the experts when it comes to the minutiae of providing care. They're not the experts, they're not the physicians, they're not the nurses. They're not directly involved with the patient flow. They're very open if you're partnering with them and being honest to say, "Hey, we need experts to help us with this. I think that's you." So, you go to the table, you be open-minded, and the very next thing you realize is that healthcare is not free. Throwing money at a problem, especially this sinkhole of medicine, isn't going to change things. So I know in the news we always talk about, it's always out there, whether it's the AMA or anyone else saying, they're missing the boat. We need more dollars here. We need more dollars here. But you can't just shove money at a problem and not realize that there is a limited amount of revenue generation coming in. We can't have a money tree just flowing. Everybody's going to make it rain when it comes to providing all and every service that we have in medicine. So those are probably my two biggest things for medical students or residents to realize is that government's not the enemy. You have to work with them. I don't care which government it is, whether it's the one we have now or whoever's going to be in there in the future. You have to realize that irrespective of your political bias that you have, these are people that are in there that are trying to make a difference, and you just have to listen and talk to them to get their perspective, to bring your perspective, And somewhere in the middle, you'll have to find a way to work together and move forward. That's the biggest thing. You can't be adversarial all the time. That gets everybody nowhere. And the one that hurts the most is the patient. The patient is the one that hurts the most when that's all you have is an adversarial relationship. You need to partner, you need to be open, move forward. And then again, the very second close niche to that is that healthcare is not free. There's a limitation on what we can pay for. And you have to keep that in mind when you're trying to come up with quote unquote solutions.
That's great to hear because I think it's a very positive outlook on what the relationship should be between healthcare providers or medical students with the government, whatever government is in place. And I think a good outlet or example of where you can do some advocating is, events such as the Provincial Day of Action, where medical students can go and voice their concerns and voice their opinions, as you mentioned, or is recommended. Now, I think that's all we had for questions and for time. So I want to thank you so much for the insight you provided both to myself and to our listeners. I think it was fantastic, and as well for everything you've been doing to contribute to rural healthcare improvement. Thank you so much for joining us.
No, absolutely, Adam. Anytime, feel free to reach out anytime. If there's any of the listeners out there that are curious about some of the things I said, I'm sure my contact info is floating out there in the World Wide Web, so they can always reach out to me. So,
All right, awesome. Thank you so much.
excellent. Thank you.
All right. So I know I really enjoyed that discussion there with Adam and Dr. Ram, and hopefully you did too. And that's it for today's episode of Stethoscopes and Student Standpoints, the official podcast of the Alberta Medical Association Medical Student Advocacy Committee. If you found this discussion insightful, make sure to subscribe and follow us for more conversations on medical education, advocacy, and healthcare reform.
And we want to hear from you. If you have a topic you want us to cover, reach out. We'd love to keep this conversation going. Until next time, keep questioning, keep advocating, and keep pushing for better healthcare.
Bye.